Hi, this is Dr. Jan Bellows, and we're going to speak for the next 45 minutes to an hour about cat dentistry. And cats are not dogs when it comes to dentistry. There's a lot of difference going on. Dogs have bigger teeth, more teeth, different disease presentations, and certainly different anesthetic protocols compared to cats. Let's start with anatomy. Cat anatomy, the first most striking thing is cats have a lot less teeth than dogs have. Cats have 30 teeth compared to dogs that have 42. And here's a picture on the left of the hard palate and the soft palate, and on the right, the sublingual area. And the sublingual area is made of the sublingual mucosa, the alveolar mucosa, gingiva around the tooth, labial mucosa, and this goes all the way around. And this is actually top and bottom. Gingiva is described as that part that surrounds the alveolar jugum, this part right over here. This is the gingiva. This is the mucogingival line here, and the area coronal to that is the alveolar mucosa. It's right over here. And then the labial mucosa. But the gingiva, responsible for gingivitis and periodontal disease, is that part that is covering the alveolus, that really tough tissue. Moving a little further back in the cat's mouth, the area that commonly gets inflamed is called the mucosa of the caudal oral cavity. At one time, it was called the fauces or faucitis, but the fauces are actually, as we'll learn very soon, on the inside of this palatoglossal fold. So when there's inflammation, which is typical in this case, in stomatitis cases, it's inflammation of the caudal the mucosa of the caudal oral cavity. More anatomy, and gingiva, get a really good feeling that this is the mucogingival line. Anything above that is the alveolar mucosa, loose alveolar mucosa. The gingiva itself is supposed to be really tight around the tooth. When you have periodontal disease, look at this picture right over here. The periodontal disease eats through or affects the periodontal ligament and allows food and debris to get into this area, loosening the gingival attachment or the periodontal attachment to the tooth itself. And in this tooth, you can see gingival recession. At this area of the tooth is called the cemento-enamel junction. And you can see the cementum is exposed here. The dentin is below it, sensitive dentin. And I bet you could put a periodontal probe in here and go 4 or 5 millimeters, if not more. Most probably this right canine needs to come out. More anatomy, the gingiva, alveolar mucosa, labial mucosa, the mucocutaneous junction, and the skin of the lip. Now in cats, they have this structure right behind the mandibular canine called the labial mucosa or the labial frenulum. And some folks feel diagnose this incorrectly as a mass that needs to be removed. It does not. It is a normal structure. And the frenulum attaches the lip to the lower jaw. And there's quite a few frenula. There's a frenulum underneath the tongue that attaches the tongue to the lower jaw also. So don't cut those. All right. Some anatomic terms: mesial and distal, facial and buccal. Mesial and distal. Mesial means towards the midline. Distal is away from the midline. Facial is that area on the outside in the rostral area. Buccal is in the cheek area. And vestibular is that little pocket when you pull out the side of the cheeks that you can view. Rostral and caudal. Rostral and caudal are terms that refer to position on the head, not position on the tooth. Position on the tooth is mesial and distal. Position on the head is rostral, towards the rostrum or towards the front, and caudal. In human terms, it's anterior and posterior, but humans don't hold their heads the same as animals do. So in animals, it's called rostral and caudal. That's positions towards the head. Let's go over different types of tooth names. Have the canine teeth, there are 4 of those. Have premolars, and then you have molars. And there's only 1 molar on top and 1 molar on the bottom on each side. The numbering of teeth is sometimes a little bit confusing. The tooth in the maxilla, the tooth immediately caudal to the maxillary canine is the 2nd premolar, then 3rd and 4th. The tooth immediately caudal to the mandibular canine is the 3rd premolar. So this is not the 1st premolar here. This is the 3rd premolar. There is no, in the cat, there is no 1st and 2nd premolar. So there's the 3rd premolar, 4th premolar, 1st molar in the mandibles. Tooth numbering is something that is becoming more common as time goes on. And the tooth numbering system is called the modified Triadan system. There are 100 series, 200 series, 300 series, and 400 series. Actually, for deciduous teeth, there's 500, 600, 700, and 800. But let's just concentrate on the adult teeth. The 100 series starts from the right maxilla, and it starts from the 1st incisor moving backwards. So 101 would be the right 1st incisor. 102 would be the right 2nd incisor. 103 would be the right 3rd incisor. Then it goes to 201, which is the left 1st incisor. 2nd is 202. 3rd is 203. Then the 300 series is the left mandibles, 301, 302, 303, and the right mandibles, 401, 402, 403. And to make it easy, I usually, I know it starts in the right maxilla, and I make it like a clock. So it goes the 100 series, 200 series, 300 series, 400 series. In the maxilla and the mandibles, all the canines end in 4s, and all the molars end in 9s. So your maxillary right canine is 104, left canine is 204, left mandibles canine is 304, right mandible canine is 404. Your molars end in 9. So the right maxillary molar is 109, the left maxillary molar is 209. And then you can see the mandibles. So the tooth behind the 404s and the 304s, the tooth behind the canines ends in a 7, which is a little confusing because you would think it'd be 304, 305, 306, but no, because there isn't any 1st and 2nd premolar, it skips to the 7s. So after 304 comes 407. All right, so that is a brief look at anatomy in the cat's mouth. Now let's talk about diseases. You have congenital diseases, but functional. And those are teeth that just show up for whatever reason in the wrong place. Normally, you would expect in the mandibles to have a 4th premolar, a molar, and then nothing else. But in this situation, we have a 4th premolar, a molar, and then a single rooted tooth. But it doesn't seem to be causing any trouble, so we just leave it alone. Same thing in this maxilla. There's the 4th premolar, 3rd premolar. This is a 2nd premolar, and then what's this? Don't know. But it doesn't seem to be causing any inflammation, and we can safely leave it alone, and that means that it is functional. Now, some things are not functional. In this cat that has a persistent primary tooth. We used to call these retained deciduous teeth, but retained teeth are classically teeth that are located subgingivally. This is a persistent primary tooth, and you can see the massive swelling because there's two teeth in the same socket at the same time. You can see just how swollen this area is. And because of that, as soon as you possibly can, you want to take out the persistent primary canine tooth. Now, in this scenario, this is a cat that is a lot older, and you take a radiograph and look what you have. You have two adult canine teeth. So this is a supernumerary canine tooth. And because they're both inflamed, I would certainly take out the back one. I'd probably take out the front one also. So the cat wouldn't have to live with that inflammation that's probably causing dull pain. So that's congenital. Let's talk about periodontal diseases. And the periodontium is that those structures that hold the tooth in the jaws. It's made of the periodontal ligament, it's made of cementum, it's made of the alveolar bone, and it's made of the attached gingiva. Normally, the attached gingiva should be right up to the cemento-enamel junction here. And normally, you should not be able to see any roots. This is all advanced periodontal disease. And the problem with leaving this tooth here is that after the teeth are cleaned, where's food going to go? Right in this area. So ideally, both of these teeth need to be extracted because they have advanced periodontal disease. And even though the front part of this tooth looks absolutely normal, the back part is in tough shape. So a tooth is evaluated by the worst part of the tooth. So in this situation, they're both advanced periodontal disease and they both need to be extracted. Periodontal disease starts with gingivitis. You cannot have periodontal disease without gingivitis. You can, however, have gingivitis without periodontal disease. And this is inflammation of the gingiva. It gets swollen and inflamed, but there isn't any support loss. So the treatment is cleaning the teeth, polishing them, and if you want to add a sealant, we'll talk about sealants at the end of this presentation, certainly can, and that helps to decrease plaque. But major go-home point is that you need to have home care, and it needs to be every day, much like our teeth. Because what will happen if you don't, then the plaque turns into rough tartar or calculus, and that will attract more plaque, which will cause more inflammation, and the inflammation will eventually yield to stage 2 disease, which is called early periodontal disease, which is typified by less than 25% of support loss. So the tooth that is normally held together really tight by the attached gingiva starts losing support, but it's less than 25% support loss is stage 2 disease. Stage 3 disease is between 25 and 50% support loss. And you can see here, normally the gingiva should be down to here, but you see this gingival recession. So this is support loss between 25 and 50%. And this is a tooth that ideally should be extracted because if a client hasn't started providing home care at this point, they're not just going to all of a sudden start and be effective. You can see how the gingiva is swollen and it's no longer knife edged, and it's no longer just gently laying against the tooth because there's a lot of tartar and plaque, and it just builds up and gets quite thick. And then stage 4 disease, this cat presented with a concretion of plaque and tartar on the mesial root of the 4th premolar. And once we cleaned it, you can put a whole dinner in there. So this tooth must come out because this is where exactly food's going to go the next time the cat eats. And you can imagine filling up your pocket with food from lunch. and not taking it out in 6 months, your leg would start to rot off. So stage 4 periodontal disease treatment is extraction. Stage 4 periodontal disease also is typified by furcation exposure, where you have the multi-rooted tooth. You could put a probe through and through, so it goes in one side and comes out the other. This is called furcation exposure. And again, this is where food is going to build, and this tooth must come out because you just can't keep it clean in that area. Another disease typified by advanced periodontal disease is called supereruption syndrome, where the body is trying to get rid of the tooth due to periodontal disease. And you can see how this left-sided canine teeth, mandibular canine tooth, is so much longer than the right side, and that's because the body is trying to get rid of it. You take a radiograph, it's always due to periodontal disease, and you can see the food and debris just get in this area, and if left alone long enough, the tooth would be exfoliated, but the poor cat has to suffer while that's happening. And also look at the degree of swelling. This is normal over here, and you can see just how abnormal this area is. It's all swollen, and the periodontal probe would go virtually down to the bottom. So to help the cat out, it's a lot easier just taking out that tooth. This is all part of periodontal disease. In fact, we don't call it periodontal disease per se, we call it periodontal diseases. So that's congenital and periodontal diseases. And now we're going to talk about fractured teeth. Cats get fractured teeth, and this is an image that one of the zoos sent me. They were able to catch that jaguar and show the pulp exposed from the, obviously the lion was, or the jaguar was chewing on the fence or chewing on a bone, fractured the tooth, and the pulp was exposed. And fortunately, we got the jaguar under an anesthetic and was able to do a root canal to save the tooth. There's different classifications of fractured teeth. And the biggest classification is complicated versus uncomplicated. Uncomplicated means that the pulp isn't exposed. In this situation, it's close because here's where the pulp resides, right there, but you don't see the pulp. So it's not exposed, but it's close, and the cat probably would be sensitive to cold and hot and pressure, and treatment of this would be to put some bonding material on it and do, because it's a crown root fracture, it goes underneath the gingiva. The treatment of choice here would actually do a gingivectomy in this area to remove the pocket, because there's a periodontal pocket and that's where food's going to go. So this is an uncomplicated crown root fracture as compared to a complicated crown fracture. It doesn't go under the root, but this is where the pulp normally is. This is where the pulp normally is. This is a complicated crown fracture. A complicated crown root fracture, these are complicated so you can see the pulp being exposed here, and it goes into the root area. So not only do you need to do a root canal, but we need to do a gingivectomy to remove the pocket. And in this situation, this is, I don't know how this cat fractured the palatal root here, but did. So this is also a slab fracture. And ideally what can be done here, because it's an acute slab fracture, you can go in there and take out the palatal root and then put something called MTA over the root exposure and restore that with bonding material, and the tooth can stay vital. That's if you can get it within 48 hours. So the treatment for pulp exposed teeth is either extract the tooth or do root canal therapy. And what root canal therapy does is removes the root if it's greater than 48-hour fracture. If it's less than 48-hour fracture, medicine can be placed on top of the pulp and the tooth restored. And this is what it looks like when the tooth is restored. So we did root canal therapy, took out the infected root, filled it with the same material that they use in humans, which is called gutta percha, and then restored the tooth. And that tooth has an excellent prognosis. The research has showed that 95% of the cases do well with root canal therapy if it's performed properly. All right, so that's the traumatized tooth, periodontal disease, and congenital. Now we're going to move to tooth resorption. It's also called root resorption. What it's no longer called is cervical erosions, odontoclastic resorptive lesions. It's no longer called FORLs because canines get them too. So, and ORLs with feline odontoclastic resorptive lesions, they are called TRs or tooth resorptions. And these come in a lot of different varieties, and there's different ways to classify them. We'll talk about the anatomical classification first, which is more for an educational reason as compared to a clinical or practical reason. The tooth resorption graded by stages is something that you can put in medical records to classify it better. But clinically, you want to focus on the types of tooth resorption. We're going to talk about stages and types. So with stages, the first stage is stage 1. And most of your tooth resorptions will start in this area, in the cemento-enamel junction, and then they will progress upward and come out of the crown somewhere. Some of them start here and then go downward, but they usually in the cats, and this is where cats and dogs are different. Dogs do have tooth resorption that is progressive, but in cats, it's a lot more progressive and seems to be a lot more painful. When tooth resorptions are exposed to the oral cavity in the cats, even under general anesthesia, the cats start chattering. So it's extremely painful in cats. And that's why the only treatment is extraction, because that takes care of the pain. So stage 1 disease extends in the cementum or the cementum and enamel. Stage 2 disease, it actually percolates out of the, just extends here and then comes right up to this area. And radiographically, it looks like this. So here's the pulp, and it looks like it doesn't affect the pulp. Stage 3 disease, it's a deep hard tissue that goes into the pulp. Stage 4 disease, it's extensive dental hard tissue affected, certainly into the pulp, sometimes on one side, sometimes on both sides. And stage 4 is further classified anatomically as 4A, where the crown and the root are equally affected, and you need a radiograph to figure that out. And you can see how it looks like moth-eaten on the root and moth-eaten on the crown. So that's 4A. 4B, the crown's more affected than the root. And 4C, the root is more affected by the crown. In this picture on the left, it kind of looks like the crown isn't affected at all. But on the right, this tooth is about ready to fracture because of the massive tooth resorption that's affected the root canal system and certainly the root. And in cats, as long as it's not exposed to the oral cavity, it is not considered to be painful. And if it's a minor tooth resorption, not stage 4, but stage 2, and it's confined to the root, we usually just leave it alone and periodically radiograph it every 9 to 12 months. And once it progresses, they don't all progress, but once they progress to the oral cavity, we would want to take out the tooth. Then stage 5 shows up as a bump. And if the bump is not inflamed, that's what it looks like, the radiograph, then we don't do anything. If it is inflamed, then we want to make an incision over it, flap it, take away the bone in that area, and sew it back. So stage 1 through 5, you can get these illustrations on the avdc.org website, avdc.org, under nomenclature. And you can see the progression of tooth resorptions and put it next to your records so you can classify them that way. The other way, and the more practical way for classifying tooth resorption, is by types. And this is really important. If you don't have intraoral dental radiography, don't classify it by types, because you can't. You cannot do this with skull films. So type 1 lesions arise from the cervical area of the tooth and extend inward and upward, up and down the tooth. Type 1 lesions are inflammatory. Radiograph type 1 lesions have relatively normal root structure. So this is that typical type 1. The root looks normal. You can see the periodontal ligament. This root looks the same opacity as that root. And the treatment of type 1 lesions is extraction. You have to take out the entire root. Root canal therapy doesn't work. You have to take out the whole tooth and the root. Type 2 is more common, begins subgingivally. Radiographically, the roots appear to be resorbing. The periodontal ligament will not readily be recognizable due to ankylosis. All right, so this is type 2 lesions. You see the crown, but a lot of times you cannot see very much of the root because it's being replaced by bone. But you could see clinically that the crown doesn't look all that bad, but you look a little bit closer and you start to see these lesions. And once you start to see these lesions, that is almost pathognomonic that there's tooth resorption going on and it's pretty bad. So with type 2 lesions, that's one that you can crown reduce. So you take away part of the crown and then sew over the gingiva. Some multi-rooted teeth have one root is type 1, inflammatory, and the other one is replacement resorption. And that is called type 3. So in this fourth premolar, this is type 1, and this root is type 2. And the way you diagnose the type 2 is that it is less opacity. This type 2 root is being replaced by bone. And this scenario, you have to take out, when you're removing this tooth, you have to take out the type 1 root, and you can leave the type 2 root and just sew over the gingiva. Here's an example. We have a tooth resorption of the left maxillary canine. Take a radiograph, and you can see this root is less opacity than the adjacent teeth, and you can see this big spike hanging out. So this is painful for the cat. So you go in and make a flap with a number 15 blade, flap it open, and then take away this bone in this area. And you do that with a large round burr, and then you suture the area closed without tension. Take another radiograph, and this area, if you come back a year later, will be gone because the body has replaced the root with bone. It's called bone replacement resorption. All right, so that's tooth resorption. Now we're going to spend some time on oropharyngeal inflammation, which is extremely common in the cats. And some cats, for whatever reason, are prone to inflammation. And they feel that it's due to a hyperimmune response to plaque. And this comes in a lot of different varieties. This is called caudal oral cavity mucositis. This is stomatitis when it's that inflamed. This cat was referred because the veterinarian had problems intubating this cat. And this cat, after a full mouth extraction and some laser treatment, actually did very, very well. So this is a lot more than just periodontal disease. Although periodontal disease and oftentimes tooth resorption is also evident in these types of presentations. Sometimes you have this significant inflammation and which would necessitate extraction, but you don't have the caudal oral cavity inflammation. And those cases, when we see that, we can render a much better prognosis of a cure. When we have the inflammation, when it's the caudal oral cavity inflammation back here, the prognosis of full mouth extraction is guarded. It works in about 60% without any other care, but sometimes 20% just don't get better without a lot more care. And a lot of that is decided if there's caudal oral cavity inflammation. Not all inflammation is stomatitis. This cat came in with a fractured canine tooth, and I felt that the swelling back here was probably secondary to infection coming in this way and coming out that way. I took a radiograph, and the bone was destroyed there, and the biopsy came back as squamous cell carcinoma. So not all inflammation is benign. There are 13 classifications of oral inflammation in the cat. All of these classifications can be found on the avdc.org/nomenclature website. So it's avdc.org, American Veterinary Dental College.org/nomenclature. And we'll start with cheilitis, which is an inflammation of the lips, including the mucocutaneous junction. Then there's glossitis. So not everything that you open up the mouth is stomatitis. It's more anatomically identified. And the leading cause of glossitis in the cat is calicivirus. Then you have tonsillitis, inflammation of the palatine tonsil. If it's unilateral, think cancer as compared to bilateral lesions. Bilateral lesions are very commonly related to calicivirus. Palatitis, cats have hard palate and soft palate, and sometimes they have inflammatory lesions caudally. This is on the soft palate. Osteomyelitis is the bone gets infected. This cat was hit by a car and had some trauma, and the bone got infected, and we were able to remove a sequestra, and the cat healed very nicely. Here's the gingiva that we talked about. The ginger covers over the alveolar bone. This is normal gingiva, but when you have gingivitis, it gets inflamed. And it's just due to plaque. Plaque causes gingivitis, plaque causes periodontal disease. Now, the periodontium, and this is where you're going to spend a fair amount of time in the cat's mouth. The periodontium, this is normal over here, where you have the cemento-enamel junction. Here's enamel, here's cementum. Cementum attaches to the periodontal ligament, which attaches to alveolar bone. And normally there's in the cat, a 0.5 to 1 millimeter sulcus. This is where the attached gingiva becomes attached, and this is the free gingival margin over here. When you have gingival recession, you have a much larger pocket, and the gingiva recedes, exposing the porous, sensitive dentin. So it's something you certainly would prefer not to have. This is the periodontal attachment. This gives you a much better view of what gingival recession winds up looking like. This is the periodontal ligament here attached to the cementum. This is attached to the alveolar bone on the other side. You can see this case that the tooth was extracted due to support loss. So this cat had greater, just about 50% support loss, where normally the support should be at the cemento-enamel junction, right in this area right over here. And you can see how it receded. These are images of gingival recession, and it's all caused by plaque that first builds up within 12 hours after teeth cleaning, calcifies to tartar, which is rough, attracts more plaque, a community begins, the gingiva gets inflamed, and you have gingival recession and support loss and pain. And it's something that you certainly would want to prevent rather than treat. Periodontitis we spoke about, and it comes in so many varieties. Anytime you see this much root on a tooth, that's advanced periodontitis. There's no way you can't give enough steroids, you can't give enough antibiotics to make this go away. These teeth have to come out. And the molar has a very interesting anatomy, which has a very thin root distally and a very thick root and conical root mesially. So when you're taking out this root, you just come up in this area right over here. So you don't go in the middle. Come right at the furcation and you go up. This inflammation is called alveolar mucositis. It's inflammation of the alveolar mucosa, which overlies the alveolar process, extends from the mucogingival lung junction. Labial mucosa is right underneath the lips and the cheek mucosa. You can see how that is inflamed in this area. Right in this area would be labial mucositis. Buccal mucositis is right on the outside, right on the lip side, but this extends also. And the reason why this cat had so much inflammation, it was born with a supernumerary fourth premolar. This is unilateral. Buccal mucositis. Some lingual mucositis underneath the tongue. Caudal mucositis. We spoke about that. In severe cases, caudal mucositis, when it gets very inflamed, is called stomatitis. So this is really the only diagnosis of stomatitis. Everything else is mucositis and inflammation, but this cat not only has severe inflammation caudally, but also has glossitis. This is secondary to a multifactorial hyperimmune response to plaque. So the treatment for gingivitis is teeth cleaning. We sometimes use Oravet and use home care. For moderate to advanced cases of oral inflammation, you extract the teeth that in the area of inflammation, or extract all the teeth caudal to the canines, or you extract all the teeth if everything's inflamed. There was a quintessential study done by Dr. Philippe Hennet in France that found that with chronic gingivostomatitis, which is also another way of saying stomatitis, feline chronic gingivostomatitis, by removing all the inflamed teeth from either teeth caudal to the canines, if the canines and incisors are okay, or taking out all the teeth, you get a 60% cure rate. 20% needed something else. And in our practice, that's every other day prednisone and a laser once a month for 3 months, the CO2 laser. And 20% weren't helped. We haven't seen the 20% not helped, because once you take out all the teeth, at least the cats feel better. The inflammation may still be there, but they don't have the teeth that keep on putting more plaque in contact with more teeth. Medical options, the big go-home point is do not use Repositol steroids. You give a cat with stomatitis a Depo-Medrol injection, the cat will get better and look great. And if you also give it a convenient injection, it'll get even more better. It'll look great for about 2 or 3 weeks. And then eventually it gets worse, because these cats don't have a steroid deficiency. They don't have an antibiotic deficiency. But treating those two things with steroids and antibiotics will help temporarily. And then the client keeps on coming in with shorter spans. So they come in 2 weeks later and it helps for 2 weeks. And then they come in a week later and then it helps for just a week. And if you keep on giving steroid injections, a lot of times you'll create a diabetic cat, and then you have even more trouble, because you have infection that the diabetes will unfortunately cause a raising raging infection. So there's a lot of things that have been tried, but there's really not very much that other than extractions that you could depend on. Interferon is a good treatment for the stomatitis. The problem with interferon is that it is only readily available in Europe. It can become, you can get it in America, but it's a hassle, and you have to do special paperwork with FDA for compassionate use. I've never used it, and the veterinarian dentists that have give very mixed results, whether they feel that it works. So anesthesia is important when you start to take out these teeth, and intubation and cuff inflammation is important. However, this is real important. This is a major go-home point. Anytime you move the cat from side to side, you want to disconnect the endotracheal tube, and you don't want to super inflate the cuff, because if you do that, what you can cause is a tracheal tear. They did an article that had 18 cases of tracheal tears, and virtually all of them were related to dental procedures, because we go back and forth and back and forth. And many of these cats do not make it. So very important not to hyperinflate the cuff, and also anytime you move the cat from side to side, disconnect the tube from the machine. Local anesthetic, we use bupivacaine, or now ropivacaine. Local blocks are real important. The ones that we use are the extraoral mandibular block and the maxillary block, and also the infraorbital block, right, by the upper fourth premolar. This is the mandibular block, and you want to get the mandibular nerve as it enters into the mandibles. You just feel for the arch and go a little bit in front of that. Very easy to do. This is the rostromandibular block, just to show you where it's given, but we really don't use this. But to be complete, I just put it in here. Infraorbital block, and the blocks basically anesthetize the teeth in front of the block. So if you're taking out a third premolar, a maxillary third premolar, or a canine, or any of the incisors on that side, we would use an infraorbital block. If you're taking out teeth behind that, we would use a maxillary block. This is the maxillary block. Patient monitoring is critical. The biggest concern with clients is anesthesia, as it should be. So these multi-parameter units are very important. Lately, I've really, it used to be the blood pressure was my most important area I would watch. Now it's the CO2, because it's breath by breath. You can see what's going on. EKG, you could have a dead cat have a normal EKG for a while. So you want to monitor these guys real well. You want to keep them warm. We use the bear huggers. We use the hot dogs. Want to make sure that you don't have hypothermia, because you can get trouble there. Extraction essentials. We use wingtip elevators on virtually every extraction, and they are sharpened in between every case. And when you're picking your wingtip elevators, you want to get a really thin face as compared to a thick face. You jam this into the alveolar socket or in between multi-rooted teeth, you're going to break the roots. This one will go right around the roots. And you want to get a whole set. You just don't want to get one or two, because cat teeth come in lots of different sizes. The Miltex ones, the short ones, fit very nicely in your palm, but the IM3 ones, the Sislak ones are excellent. So you can't go wrong with them, but look at the size of that. And the sharpening is really easy, like sharpening knives. You get a stone, Arkansas or an Indian stone, you put a little oil on there, and you just go back and forth on the knife edge. And sometimes when we're doing complete or full mouth extractions, we do sharpening in between. And then after they're sharpened, take a little alcohol swab and clean the face. Illumination, also really important. I like the perioptics. My dental resident, Dr. McMorrin, likes the Surgitel loops, but they help with magnification and also make sure you get illumination. Really, really makes it easier to see these small teeth. I can't overemphasize the importance of intraoral radiology. Digital is fabulous. And if you were taking out this tooth and you saw that the tooth had tooth resorption, you want to take it out, but you didn't know that this root practically doesn't exist, you would think that you only got one root out and you really have to go diving for the other one, but you don't. So radiology is just so important. And there's certainly a learning curve with radiology, but the learning curve isn't all that hard if you understand that from most places you do a bisecting angle technique, which is kind of like a 45-degree angle to see the teeth. This is the cheek teeth. And in the mandibles, you can use a parallel technique where you place the sensor in the gully and then go perpendicular to that with the tube head. But everywhere else, it's 45 degrees. And this is the goal is that a full mouth series shouldn't take more than 10 minutes. This is doable by putting your technician in a room with a skull or a cadaver specimen and letting them practice that way rather than initially on a live case. All right, treatment. Sometimes we can get away with selective extractions if the incisor teeth look good, the canines are a little inflamed, but certainly not as inflamed as the cheek teeth. So in this scenario, I took out everything behind the canines, and you can see how really nice they healed. Here's another case, very similar. And we knew that this case was going to have a great prognosis because it did not have a caudal inflammation. Other areas of selective inflammation, you take a radiograph and you see this bone loss here. And the bone loss is typical for stage 4 or advanced periodontal disease. You actually see the root. So you know you're going to take out this area, this tooth. You're going to take out the upper 4th premolar tooth also. This is what it looked like right after surgery. And you can see how beautifully they heal. So this is before the inflammation, and this is after surgery and how that nicely they heal. Here's that cat that had the supernumerary 4th premolar, and it's a unilateral inflammation. I took out the teeth on that side and the bottom, and you can see how beautiful they heal. Cats, if you give them if you do what's right, they will usually heal really nicely. So here's how we take out the teeth. I first put a little dot with a Sharpie on the teeth we're going to take out. Then I take the blade and incise around the sulcus as far as I can go. Then I take a number 2 Molt flat periosteal elevator to separate the attached gingiva from the alveolus. That's probably one of the more important parts. And we really like this number 10, number 2 Molt elevator flat. And we do it on both sides. This is the lingual side here, and this is the buccal side here. Then using the drill, take away the alveolar bone, and then separate the multi-rooted tooth into single-rooted segments. So here's a double-rooted tooth, here's a triple-rooted tooth, separating the palatal root. And then when it's closed, take very large bites. This is use catgut on a P3 needle, really large bites. Sometimes you do simple continuous, but usually simple interrupted. There you go. Well, this is an example of full mouth extraction. You see how all the inflammation has gone away. Here's another example of full mouth extractions. This is beforehand. This is how nice it healed. Here's another example. And the reason why I decided to do full mouth extraction is because every tooth appears to be affected. So you take it out. And I generally do this in one sitting because I have good helpers, but you could do this in 2 or 3 sittings. Just tell the clients beforehand, this is going to take some time. It's going to take about a month to accomplish, and we're going to do one quadrant at a time, or the maxilla one time and the mandibles the other time. You don't have to do it all in one sitting. Some of these cases are persistent, especially the 20%ers. And for those, I use a laser once a month for 3 months, and I usually get success with that. And what the laser does is cut down this real estate. It takes away a lot of the places where bacteria just wants to sit in there. That's what it looks like after it's lasered, and they tend to heal nicely. This is a case of juvenile mucositis where we radiographed and took out the teeth that were affected by periodontal disease. And fortunately, the cat outgrew it. And that's what happens in a lot of the cases. We also use a therapy laser postoperatively to remove some of the swelling. Go home pain relief, fairly large use of Onsior and fentanyl patches in cats that don't have any children in the family, and they respond very nicely to that. For plaque prevention in cats, as compared to dogs, we recommend toothbrushing or dental wipes, but cats, we recommend Q-tips, those Q-tips that you use for your ear cases, and you hold it like a pen, and then you dip the tip in tuna water. You tell the client to do that. Tuna water does nothing medically, but it helps to make the cat happier about the procedure because they like tuna fish. Oravet is a product that I did the research for Pharmacia at the time and showed that it is very effective in cats to help control plaque. Unfortunately, most cat owners won't use it, but if you have a cat owner that will use it once a week on dried teeth, then it can be very effective. Sanos is another really good product that is applied at the time of teeth cleaning to decrease the accumulation of plaque. Sanos is VOHC accepted. And VOHC is the Veterinary Oral Health Council, and it accepts products that have shown to decrease plaque or tartar by at least 20%. And there are many cat products, a lot more dog products, but you can go on their site and download this PDF, and we hand it out to all our cat clients at the time of teeth cleaning. So they can order it. We have them ordering it online. All right. So how does this all fit into your practice? So here's a client that comes in the morning with a cat in its cat cage, and we take them back by 10 o'clock. We do the preoperative testing. Then we use general anesthesia on them. We're putting a catheter in. We take dental x-rays. Then we scale them a tooth by tooth examination. And at that point, after they're probed and I speak to the client about it, then we look at the radiographs, put it all together, and tell the client, okay, this is what we found. This is what we want to do. The cat's still under general anesthesia. And we tell them that, okay, this area has a little periodontal disease, and we're going to wind up putting the periceutical, which we like to use clindamycin or clinderol, and this tooth resorption area, we extracted that tooth. We took radiographs afterwards, and now it's 1:43. Placed Sanos before the cat wakes up. It's 2:37 now, the cat's up. We prepare a report for the client and then go home when the client goes home, we review what was done that day. And then we have the client come back a week later to show them how to perform home care. We don't show them the same day of surgery. because it's kind of painful for the cat, but a week later they're good. And then not only do we show the client how to perform home care, but we put the Q-tip in the client's hand and let them show us that they know where to apply the tuft. All right. So what do we learned? Cats have certainly different oral diseases. They have different anesthetic protocols. They have different instruments that we like. There's good ways to do plait control, and there's a certain workflow that actually works. Hope you enjoyed it. If you need to contact me for anything, give me a buzz or give me a email, dentalvet@aol.com. Thank you.